Good morning and welcome to this morning's InnoScot Health Ophthalmology Innovation Call information event. Thank you for joining, whether you're joining live or recorded. We're grateful for you taking the time to join the event this morning. My name's Graham Watson. I'm the Executive Chair of InnoScot Health, and you'll be hearing from me and a number of my colleagues, as well as some colleagues from within the NHS during the course of the event today. And we thank everyone for taking the time to present to you during the course of the morning. Just a couple of housekeeping items. If you've got any questions for any of the speakers, then there's a Q&A box button at the top of your page. Please enter the questions there and we'll collate them and address them, hopefully all at the end of the event later. The meeting this morning is being recorded and the slides from today will be made available on the InnoScot Health website after the event concludes. And if you require closed captions, please select the relevant box from the More tab at the top of the screen. So without further ado, let me just start the event now and welcome, as I say, welcome you all to our call. This is a further innovation call. We've already had a number of these successfully launched over the past couple of years. It's something we started doing during the early period of COVID, and we're delighted with the success that they've had. And this, of course, hopefully will be another successful call for ideas and initiatives. InnoScot Health has been working in partnership with the NHS in Scotland now for over 20 years. We celebrated our 20th anniversary last month. And our mission has remained consistent throughout these 20 years to inspire, accelerate and commercialise impactful healthcare innovations that are generated by staff within the NHS here in Scotland. We formerly were called, you may have been more familiar with our previous name, Scottish Health Innovations Limited, shortened to SHIL. As part of our 20th anniversary celebrations, we took the opportunity to refresh both our identity and our name, hence InnoScot Health, our new corporate identity. We've invested considerable amounts over the last couple of years in particular in our digital offering. InnoScot Health is a relatively small team, numbering no more than 20 members of staff on full-time roles, and of course serving the needs of a national health service across the length and breadth of Scotland means that our digital offering is really very important and something that we take pride in having some of the best ideas and best people working on that particular aspect of our business. We have a unique role working with virtually every health board in Scotland in unlocking the know-how of NHS staff. InnoScot Health is funded by the Scottish Government through the Chief Scientist Office. We have 3 shareholders, both the Chief Scientist Office representing Scottish Ministers, NHS Tayside and the Golden Jubilee National Hospital. But we are a not-for-profit organisation, as I say, working with our colleagues throughout the NHS to take ideas from a very early stage that we feel have the potential to primarily improve patient care, improve treatment plans, but also generate income for health boards and innovators throughout the process. And we bring to bear a range of skills in that respect, from project management to regulatory advice, product development, financial planning, and other relevant skills, funding related skills, so that we can wrap around the idea everything that's necessary to take that particular idea from its inception, often in a very raw sense, to market in a commercially successful way. And we've been doing that, as I've said, for over 20 years. Our new look branding through our website and our various social channels, which you'll see on the next slide, is really designed to enhance and drive engagement with healthcare professionals throughout Scotland. We've taken a considerable amount of time to look at how we can best communicate with a range of stakeholders and those who are interested in bringing ideas to market, and our website and our relevant supporting social media channels are designed precisely to do that. And we're at the midway through, I would say, that our ambitions and our plans for this new digital offering. We have other ideas that we will be launching over the course of the coming months. But if you take the time to look at the website, I think you'll hopefully find it's a very easily navigatable experience, something that you will be able to find ideas, support for learning experiences, case studies, and be able to tap into the expertise of our team in advance, perhaps, of actually meeting face to face. Of course, now, as we're emerging successfully from the pandemic, we have members of our team who are located throughout Scotland, in the north of Scotland, in the Tayside region and the Lothian region, and in the west coast, so that we are able to get out and about to health boards, to meet with innovators, to meet with those who have ideas, to explore the potential for the idea, and ultimately, hopefully, to be able to work with as many of you as possible over the course of the development of ideas. Over the course of our 20 years, just to give you an idea of the range of successes that we've had, we average around 100 ideas being brought to us every year, and these are generated from staff across the length and breadth of the NHS, all the areas of the service, as well as externally as well, where we can work with the NHS to support the idea and to bring it into market-ready form. So 2,000 ideas over the course of our 20 years. So the ideas, by the time we decide to take them on and work with them, we already have done a considerable amount of work to give ourselves the confidence that with support, there's a possibility that the idea might be commercialized. Of course, not every idea that goes through that process ultimately is able to be commercialized. Many reasons why things take turns during the course of development that ultimately make it a challenge to take them to market. But nevertheless, over the course of the last 20 years, we've been able to protect, i.e. take to market, in a sense, over 250 ideas that have come through different aspects of the NHS, and we've commercialized these through historically direct selling. We don't do that now. What we do now primarily is license ideas to partners, the partner organizations, where there's perhaps a company that already has a presence in a particular sector and is better able to take the idea to market than we would be able to do directly. So we have partnerships with many corporate partners around the UK to take the idea into market, and indeed internationally. Many of our ideas that have been successfully commercialized have been taken internationally as well, which is something we're very proud of. So apart from our license program, which is a very active one, in certain cases it tends to be rarer than being able to license an idea. We might actually spin out a company, and over the course of our 20 years we have successfully established 7 companies employing obviously a number of people here in Scotland and elsewhere. And these companies, some of them have already been bought out and have moved on to a different form of ownership, but others are still in their development phase, where we, as InnoScot Health, are a shareholder on behalf of the health board, on behalf of the innovator, as well as those who have invested in the company directly, whether these be at an early stage of development, high net worth individuals, or venture capital funds. So a successful portfolio of established organizations that we've worked with, a successful portfolio of companies that we've been able to partner with, and as I say, a number of spin-outs that have successfully launched in the market. So one of the reasons for having these calls is that we're keen to focus our resources on areas of need within the health service, and rather than perhaps be random in the areas that we work with, to bring a degree of focus into a number of areas. So previously, innovation So very targeted, very focused calls, and of course this ophthalmology one is the next in that sequence. Next stages for our digital presence, just very briefly. We'll be doing further webinars. We find these a great way of sharing knowledge and hopefully educating colleagues around the country. We're making it easier to communicate with us through our chat bot that we're developing, and we'll be, of course, working on other innovation calls as time unfolds. So hopefully you'll have the opportunity in the next 50 minutes or so to get a real sense of what we're doing in our ophthalmology call, and you'll be enthused and interested to make contact with us. And we'll be delighted to hear from you, we'll be delighted to work with you, and we'll be delighted hopefully to see some real successes and some transformational ideas emerging from our work. So with that, I'm going to hand over to my colleague, Dr. Robert Ray, who heads our innovation team, and Robert's going to take you through how the actual call works in practice. So over to you, Robert.
Great, thank you very much for that, Graham. Thank you for that introduction. As Graham said, my name's Robert Ray. I head up the innovation team at InnoScot Health. What I'm going to do for the next 10-15 minutes or so is really put a bit of context into why we're doing an innovation call in the area of ophthalmology at the moment, looking at some of the background there, and why there's a real need for innovations in this area. As Graham has said, you know, we've run innovation calls for a number of years now. We tend to do about 2 per year. We target these at specific areas of need. So, for example, last year we did calls, excuse me, in the themes of sustainability and on frailty. And we're looking to try and tap into the expertise of healthcare professionals, so the people working at the coalface in the NHS who are problem solving every day, who are innovating every day, even if they don't realise that they're doing it, because these are the people that are really key to generating these new ideas and these innovations that will make a big impactful change into patient care and improve patient outcomes. So we'll go to the next slide. So I'll explain in a few minutes, you know, why we've chosen ophthalmology, and I won't bore you with too many graphs. There's a couple of histograms in there which will illustrate the point a bit later. But as we all know, you know, the pandemic has really impacted a lot of areas of healthcare in a negative way, particularly in terms of things like waiting lists, putting pressure on staff. Ophthalmology, very much one of those areas that has suffered. You know, even something like people with eye conditions not being able to access their high street opticians, optometrists, or get to ophthalmology appointments. In case any of you didn't realise it, today is actually World Sight Day, which is a great reason for doing this event today. And I think it really highlights the importance of why we need to think about you know, improving eye care, helping people with long-term chronic conditions, and overcoming the challenges that the pandemic has thrown at us. If we go to the next slide, please. So in preparing for this event and preparing for this call, we've spoken to a number of colleagues in the NHS, sort of leading ophthalmologists, people who are active in clinical work and research. Professor Roshni Sanders, who's the NRS lead for ophthalmology, was very kind to offer us some guidance and help for that. She particularly highlighted the need for innovations relating to glaucoma. Glaucoma, of course, very common chronic eye condition that can have very serious consequences for your eyesight if it's not treated properly. And she mentioned the fact that, you know, of the 60,000 glaucoma patients in Scotland, only half of them have actually been seen due to NHS backlogs. And that applies to various other eye conditions as well. And so what we're hoping with doing this innovation call is, for example, people will come forward with ideas, solutions, innovations for things like glaucoma, to treat people at home, to monitor at home, to help ophthalmologists and high street opticians. Next slide, please. Other people we've spoken to have highlighted other areas of concern, so things like diabetic retinopathy. Of course, unfortunately, the number of people in Scotland and the UK with diabetes is increasing year on year, and diabetic retinopathy is one of the consequences of that if it's not well treated and well managed. Age-related macular degeneration, we're an increasingly aging population, and this is a condition that's getting more and more common. Glaucoma I've mentioned, and cataract being one of the most common reasons for having surgery and for attending a hospital inpatient or outpatient appointment. Dr. Ian Livingston, ophthalmologist at NHS Forth Valley that we've worked with for a number of years, has highlighted in particular that he sees the future of ophthalmology as being very much a mixed thing. So not just relying on traditional techniques, but leaning also more heavily on digital, on things like virtual and augmented reality, and particularly, doing things more long distance. Scotland is, of course, an unusual country in that we have a lot of people living in the central belt, but not many people living up in the Highlands in the north, and those that do live there are in very kind of remote, dispersed communities, but all of them should have access to the same level and standard of healthcare. And people like Ian and other ophthalmologists see that as a real challenge as getting the same standard of care to those people and using sort of more long distance techniques, more kind of computer-based consultations and asynchronous consultations as being the way forward there. If we go to the next slide. So just a few statistics here, again, just to enforce why we've chosen ophthalmology, why we're doing this. I'm sure a lot of people know pre-pandemic ophthalmology was the largest hospital outpatient speciality. I've mentioned that already in relation to cataract. There are a number of programs and solutions that the NHS is developing to try and overcome that by investing more money, but also putting in place new programs and new initiatives. So, for example, the new National Low Vision Service, which will greatly increase the level of contact between ophthalmologists and community optometrists to improve care there. As I said already, there are a huge number of people on NHS waiting lists, and a large part of that, certainly NHS England and NHS Scotland as well, is for ophthalmological treatment, and it's things like glaucoma and cataracts. Those are the things that people are waiting for. And if we look at the next slide, as I said, there's just a couple of histograms, and not to kind of draw this out too much. This one really shows that actually ophthalmology isn't alone in being something where people are waiting to be seen longer than usual and are struggling to be seen. The number of new ophthalmological outpatient appointments is reduced in the quarter ending 31st of March this year compared to what it would normally be, so pre-pandemic. As I said, ophthalmology is not alone in that. And in fact, if you look at some of the other specialties, you could say that ophthalmology is actually doing a bit better than things like dermatology or ENT or gastroenterology. But it does highlight the fact that there are still thousands of people there who are waiting longer to be seen than they normally would, and they would have pre-pandemic. And the second histogram on the next slide also kind of indicates this as well. This shows how long are people actually waiting to be seen. And again, ophthalmology is actually probably one of the better disciplines and better specialties here, certainly when compared with pediatrics and cardiology. If you look at this towards the bottom of the graph, you can see that it's around 40% of people are waiting less than 12 weeks for an ophthalmology outpatient appointment, which is great. But then if you look at the rest of that ophthalmology bar, there are still 60% of people waiting longer than 12 weeks, and sometimes people are even waiting 27 to 39 weeks, or even up to a year. So clearly, all of these specialties, all of the NHS is still struggling, still trying to get through the backlog, and ophthalmology is not alone in that by any means. Go to the next slide, please. So if we ask then, what is the NHS doing? What is Scottish Government doing to try and tackle this? There are a number of initiatives and things going on. I'll just highlight a few of those. The Scottish Health Industry Partnership, which is a fairly new body set up by the Scottish Government, is very much focused on helping NHS Scotland to recover via reducing outpatient waiting times. And part of the reason we're doing this ophthalmology innovation call ourselves is because it ties in with an initiative that they're also doing. They're also put out an ophthalmology or eye care related challenge at the moment as well, to try and work more closely with business and industry that is developing solutions in these areas. Just to mention what some of the NHS boards are doing. So back in 2020, NHS Forth Valley had what it's called an SBRI so a small business research initiative competition, where basically they were given a sum of money by the Scottish government, and they went out to try and find companies who would develop solutions for them, in this case based on the theme of next generation home vision testing. And the idea there is that companies benefit by getting money to grow themselves, and they get access to the NHS, and the NHS gets a solution that it needs and can use. And this autumn, in 2022, NHS Forth Valley are also leading another call, all to do with home glaucoma monitoring. As I've said, glaucoma is one of the most serious chronic eye conditions, and there's a real need for this kind of solution, and to get businesses and industry involved in this. And it's really to look and try and develop disruptive, innovative solutions that focus on home or near patient glaucoma monitoring. That's very much taking it from an industry point of view. As Graham has mentioned already, at InnoScot Health, what we do is we work with the clinicians. So we take ideas from clinicians and people in the NHS that have that, but of course working very closely with the health boards, with SHIP, and with other organisations to do that. If we move on to the next one, please. So what kind of things are we looking for then? I'm not going to go through this in any huge detail. I'm sure, working in the field of ophthalmology, there are lots of areas that you can think of where there is a need, where there's an unmet need, where there's a problem to be solved. Typically, the things that we've worked on in the past would be things like tools and devices. So, for example, things that might make the administration of eye medication easier, particularly for people who have restricted mobility. There's a project we're working on at the moment that is seeking to do that. Equally, looking for things like training tools, so ways to improve the training of staff, particularly junior doctors and nursing staff who are just coming into the ophthalmological field. Home monitoring, as I've mentioned, that's been a really important area for the Forth Valley SBRI call 2 years ago. So anything that improves home monitoring, anything that allows people to sort of manage their condition themselves better, particularly when they live in remote and rural areas and can't get to their GP more easily. In a much more tangible way, things like surgical tools, so devices and tools for improving eye surgery, and also diagnostics as well. So it's not just about the treatment, it's about the diagnosis as well. Things that enable better and earlier diagnosis. All of these things and more are the kind of ideas, the kind of solutions that we're looking for people to come forward to us and that we can work on. If we move on, please. So how can you get in touch with us? Very simple. We have a website, InnoScot Health, InnoScot.com. I put the link in there for the call, and it's InnoScot.com themed calls. There's more information there. We'll explain a bit later on. There are other ways to contact us as well. But if we move on to the next slide, please. So if you have an idea, if you've got a grain of idea, if you've solved a problem but you don't know what to do with it, what should you do? Well, of course, come and speak to us about it. We're always happy to chat. A good place to start, really, if you have a solution but you don't know where to go with it, is to try and think, who would actually use it, where is it needed? InnoScot is very much focused on commercializing solutions and commercializing new ideas and getting them out there. And in order to do that, we need to know what is the market, who's going to use it, where is it needed, who would actually buy this and use it, who's the customer. And equally important, does it improve current practice? Does it actually fit into the way ophthalmologists currently work, or is it disruptive? Is it really new? Is it going to save time as well? It's equally important to whether a new device or a new solution is a financial success, is whether it saves the NHS money. Does it save time? Does it save resource? Does it help the NHS in that way? And what sets it apart from other things? If we go on, please. So again, very brief overview. This is what we do. We offer a lot of different services. As I've said, if you have a solution idea, you can come to us and chat about it, and we will do our best to try and support it and develop it and take it on for you. My colleague Elaine Gemmill will talk a bit later about a case study, an example of an ophthalmological solution that we've developed and commercialized all the way. This has all been done under ISO 13485, which is the standard for medical devices. And we offer regulatory support as part of a package of other expertise, which includes everything from funding and investment for an idea, developing it, project managing it, commercializing it, protecting the intellectual property content as well. So we try to offer, if you like, a one-stop shop for NHS staff to come with their idea, and we'll work with them, apply all of these areas of expertise, and take it on and take it forward. If we go to the next one. No projects really that we take on are developed entirely in isolation. I think pretty much every project we've done has been in collaboration with academia and with industry. But some people might be asking, you know, what's the advantage in coming to you? Well, several reasons. Partly the expertise, partly the fact that we recognise that NHS staff have full-time jobs, that you don't have the time to devote to this necessarily. You may or may not have the money to do it. You may or may not have the expertise, and we try to take that burden on for you, but working closely with you at the same time to do that. We try to offer a very fast track, speeded up way to get innovations onto the market, bearing in mind that a typical new medical device can take several years to go from concept to being available for sale. But in any case, every idea, every solution that comes to us is treated with confidence, and we try to review it and work on it and develop it as quickly as we possibly can. And if we decline a solution, if it's not one for us, we will always try to help you find a way forward if you still believe in it, if you still think it's has merit as well. Next slide. Just a few facts then about the process. So if you are coming to us with an idea related to this call, I've listed there, you know, some of the things that that we look for, that we need, some of the support that's available. As I said, regulatory support, project management. Submitting your idea is very, very easy. You can ring us up, you can email us, you can talk to us, but we have also on our website an idea submission form, which is very short, takes about 5 or 10 minutes to complete. And once you submit that, that will go to one of the innovation managers, who will then respond to you and come and meet you and talk to you about your ideas. And really, just to finish, all ideas are welcome. Over the years, we've had, as Graham has said, you know, over 2,000 ideas in the last 20 years. Some of them are ingenious, some of them bizarre, some of them are weird, some of them are extremely clever, some of them will make lots of money, some of them won't. But in any case, all ideas are welcome. And what I would say is very often it's the simplest ideas that are actually in some ways the best, the easiest ones to develop and the easiest ones to get out there, and often actually the best ones for improving patient care. Next slide. So I'll finish up there then. What we have up next is a chat with Dr. John Ellis, who is a consultant ophthalmologist at Nineworld Hospital in Dundee, NHS Tayside. John unfortunately wasn't able to be with us today, but he very kindly agreed to pre-record a short section for us, which is basically me asking him some questions about innovation, about his work as an ophthalmologist, and about what he sees as the current areas of need in ophthalmology. Hello everyone, I'm joined now by Dr. John Ellis, who is a consultant ophthalmologist at NHS Tayside with an honorary contract at the University of Dundee. He's going to answer some questions and have a bit of a chat with us about ophthalmology as it is in 2022 and some of the needs and wants there. So John, welcome to you. Thank you very much for chatting to us today. Could you just introduce yourself and tell us a little bit about yourself, your professional background, and why you chose ophthalmology as a clinical specialty?
Yeah, I remember I went to university in Glasgow, I applied to the engineering faculty to do mechanical engineering, and after the closing date, I got them to transfer the application to the medical faculty, which made for a really difficult entry interview, because of course you're supposed to say, I've always wanted to be a doctor, which clearly wasn't true. Then I went through medicine and I always wanted to be a surgeon, but when I saw some aspects of surgery, I was a little bit disillusioned because of what I perceived to be lack of precision. And when I came across ophthalmology in my 4th year, I just fell in love with it, because it is the perfect occupation for people who have a really annoying character trait of being pedantic and picky and small scale and exact to a fault. So the kind of person you don't want to be a dinner companion is probably the person you want to be your ophthalmologist.
Okay, thank you. obviously we're running this, this innovation call, aimed at ophthalmology and ophthalmologists and, opticians, optometrists as well. Can you tell us as a clinician what the word innovation means to you and what experience you have of it, if any?
I think medicine is, as well as a body of knowledge and a training, it's also a subculture. And I think within the subculture, innovation is revered. I think the idea of standing on the shoulders of giants, which is to say we wouldn't have what we have unless somebody had innovated. And there are sort of maverick narratives of people who've done really courageous things. Of course, Jenner with cowpox, deliberately giving him himself or whatever, and Marshall with the H. pylori stuff. So these stand out, but the general underlying principle of innovation is predicated on the fact that without it, we don't just stand still, we go backwards. So innovation is revered. I've no doubt about that. I think what frustrates us all in healthcare now is that the body of healthcare is the size of an oil tanker, and it's very hard to turn it, even when you see things that are self-evidently virtuous or good. So you can see the promised land long before you can steer towards it. And I think innovation and those who act as facilitators of innovation are doing a phenomenally important thing. Okay.
Could you give us now maybe an overview of which areas within ophthalmology are really in need of innovation in 2022? What are the main areas of unmet need that you see as a clinician?
That's a good question. I'm going to kick off with what I think, and then I'll pause afterwards and see what I've left out. But cataract surgery is massively in need of innovation for the reason that it is just numerically such a monumental problem. Cataract isn't an illness. You may go to your grave without a heart attack or cancer. You may die of whichever one you don't have, but we will all, if we have enough birthdays, get a cataract. It's just aging. Therefore, it's better to conceive of it as a public health problem than as an illness problem. And if it's a public health problem and everybody has two eyeballs, you're going to have massive logistical innovation changes to deliver what you need to deliver to the population. And post-COVID, the catastrophe is that we've got, if you look at the GDP tables on the internet, Britain is in the place of 6th in the entire world's 200 plus nations. The 6th richest country on the planet, people will be dying with visual disability because we can't get to them with a 6 or 7 minute operation that we know is 98% successful. It's all very well to innovate when you don't know what works, but if you know what works and you just can't get it to the population, that's heartbreaking. So the innovations are, to my mind, the operation, once it's hit 98% plus success rate, doesn't need to be improved. It just needs to be rolled out. And so all the gains are in the marginal gains of getting a process that serves people. So there was my plug for cataract. In terms of what I might have missed out, all the aging diseases, so macular degeneration, the back of the eye, which is being treated with injections because stomach acid destroys the tablet, even into the vein, doesn't get to the eye. You have to have the injection right to the site of need. And that is clearly, again, once the science has proven it works, it's clearly logistical. How on earth do you get elderly folks up for repeated investigations and treatments? And lastly, glaucoma is in that category because it is a variation on the theme of aging of the optic nerve. So with high pressure and the treatments for that. And again, it's very, very physician intensive. So the advantage with cataract is almost fire and forget. You can treat and discharge. Those other two conditions need pretty much lifelong surveillance.
Okay, thank you. You mentioned, of course, COVID there in the pandemic. Very topical question, but how damaging do you think the pandemic has been to overall eye health? And do you think it's created a need for innovation in certain areas or in certain specialties within ophthalmology?
Yeah, well, let me speak again first for cataract. So what happened during you can look up on the internet any graph showing cataract activity during the pandemic, and it just plummets because, quite rightly, it's hard for us to do the imaginative work to remember how bad we were afraid when we saw the pictures of Italy, and we therefore had to prioritize life-saving treatments. So all the elective work was cut down, and rightly so. But these people didn't disappear, and so what is best conceived of is what happens in a large boat when you have a bow wave, and it's not dealt with; it's just pushed ahead of the boat. So we have pushed from those 2 years a bow wave of blindness into 2022, 2023 and beyond. Prior to that, we did 42,000 operations a year in 2019, for example, the last complete year. It should be 53,000 by the year 2030. and we're already at 59,000 people waiting. So we are where we would be in a time machine in about the mid-2030s without the increase in human resource and physical resource. So that bow wave is massive, and it's, you know, numbers are easy to talk about, but every number is a human misery story. It's significant stuff for real people.
Okay, thank you for that. Eye healthcare is obviously something that, you know, it's not just limited to secondary care, it goes across, you know, primary and health and social care, community care. Do you see a need for any new ideas and innovations more within those settings, or things that would kind of tie into the sort of secondary care setting where you work?
Yeah, it's really interesting. If folks on the meeting or on the call are coming from other health disciplines, what is reasonably unique to ophthalmology is that the primary care gatekeeper to our service in secondary, and I don't mean it to be patronizingly that way around, I just mean that the primary care relationship to ours is optometrists rather than GPs, and that's reasonably unique. So the other exceptions might be orthopedics and dentistry, which have other channels in, but we are served in the high street by, you know, all these wonderful optometrists who do good work in primary care, and they too have been affected by the pandemic. So there's a backlog there. But I suppose I'm sort of dancing around your question. I think the answer to the question is that the way to get forward is to have much better interface and relationships between primary and secondary care. So optometry and ophthalmology need to view one another as allies and not in different silos. We need to work to consider each other as a contribution to the workforce of the other discipline. So primary care, as well as supplying spectacles, is obviously triaging and sending on pathology, including cataracts and all the other conditions. So the strains are being felt in the high street. There are all sorts of commercial pressures in the high street. So the internet's a wonderful thing, but by democratizing eyeglasses provision, it has undercut some of the historical relationship that optometry has with patients and citizens. So they are moving in uncharted territory, and it's not a good time to have a pandemic if you're having to renegotiate your relationship to patients and citizens.
Yeah, absolutely. That's an excellent point. Well made. Last question then. Do you think, or do you find there any particular barriers for innovators and for doing innovation within the NHS? And I don't know if you have any thoughts or opinions about how those might be removed to sort of help people like you that want to pursue innovation within the NHS.
That is the core question. And here's an idea. I believe Microsoft used to have a department of ideas, and they would be given a pretty big budget. They would develop an idea, and if an idea didn't work, they would have a funeral for the idea. They would have a cake, they'd bury it, and they'd move on to the next project. And you can't have a success rate of 100%. You're going to have some innovations that seemed good but didn't work. So number one, don't be afraid to try. Number two, it seems to me that there are some innovations which are, they may be useless, but they're clearly not unsafe. They may just be benign, but fairly unnecessary. But if you're wrong and they are in fact useful, but they are not dangerous, it would seem to me that we need to have a fast track system. The reason that I would find it easier to innovate in the independent sector and the private sector is not because that's where I want to be. In fact, I emphatically don't want to be in that sector. I really believe in the NHS and want to make it work. But if I came up with a good suggestion and said to the CEO, I think by Monday we could do this for our patients and it would double the throughput, he would probably shrug and go, let's do it then. And I think there's a legitimate reason for inertia. Inertia prevents mavericks from doing silly things. I get that. But there is also a degree to which inertia stifles progress. And we don't have the luxury post-pandemic of waiting to, I've been told just today, I heard that something was going to be a couple of years to implementation. Every year that passes, the average age of cataract surgery in the UK is 76. The average mean life expectancy for men is 80. So 4 years of life will be spent with surgically treatable levels of visual disability. If it takes a year and a half, you can work the percentages out of your remaining time spent in visual deprivation of some degree. A study this very year, February this year, in a very prestigious journal showed that cataract surgery probably reduces the risk of dementia by 30%, and that the risk reduction is preserved for up to a decade, 10 years. I jokingly said at a meeting that the government should say that all psychogeriatricians should be compulsorily retrained in doing cataract surgery, because there's no medication on the market that's as good as that. You can't wait. You cannot wait for society to just slowly shamble into the future. I mean, it's been said that COVID was like building an airplane in the air. We are having to do things on the run, and they won't all be perfect, but it's no victim-free crime. If we fail to innovate, people suffer. So when people say, but if we innovate, people may become to harm, please don't measure that against the imaginary no harm corollary. There is no obverse side of that is zero risk. We've got to change. So I think some kind of body that would fast track things and look at things critically and fast, I think that would be the best possible thing.
Great. Well, thank you very much for that. Thank you for
pleasure.
For your passion and your enthusiasm too. Thank you very much for your time, Dr. Ellis. Okay, so that was Dr. John Ellis there, and a huge thanks to John for taking the time to speak to us today. Last up today, we have my colleague Elaine Gemmell, who's going to talk through a case study to give you an example and a bit more of a tangible, realistic view on how we actually develop ideas, and in this case, it's an ophthalmological one. So I'll hand over to Elaine now.
Thank you. If you could just go to the first slide, please. So this is a case study of an ophthalmic device that was developed as an innovation that came to us at some time back, but it's a great example of an end-to-end activity and how we have engaged with the NHS to put products in place that actually help patient care. Next slide, please. So it's a multifocal imager which implements the technology of multifocal electroretinography. The multifocal ERG, as it's known for short, is a medical device that provides information about the structural and functional health of the retina. This particular device was developed by David Keating and Stuart Parks, who at that time were based at the Tennant Institute in Girton Naval Hospital in Glasgow. This was a system that had been built up over time, so it was being used clinically. It had been developed in-house and was being used on patients to gather information both about research and about the clinical efficacy of the system that had been built up. After it had been in place for some time, we were approached to see if we could commercialise the system. At the time when we came to it, it was quite a large system. It was a typical lab-based system. It was very functional, did exactly what was required, but it wasn't very pretty and it wasn't very commercial at that time. The system had been put together with more than 16 years of research experience and more than 7,000 patients at that time. The system had been used on them, so there was a lot of data about how good and the value of that function for patients. It comprised of both hardware and software, and it had built up over a number of years, so it had been used for many different things. It had been used for clinical assessment, but it had also been used over the years for research projects. So it had grown arms and legs, and it was actually all singing, all dancing. But when the research activity had finished, there hadn't been the sanitization to clean out that software. So it was a big piece of software with a lot of redundant functionality. So in order to commercialize that, we had to make sure that, first of all, the software was sanitized in such a way that it could be fully documented and tested. And in doing that, Scottish Health Innovations, as we were at the time, engaged a number of partners to help us do that in partnership with the developers. So there was also the possibility of making this product available outside of the UK. So we had to make sure that any solution that we put in place would satisfy all of the markets. So the hardware also had to be shrunk to basically a way that it could be contained in 2 very small boxes, and in that way it would be readily acceptable throughout all of the clinics that it would be used in. Finally, to take the product to market, there was clearly going to have to be a regulatory pathway put in place for that. And at that time, as UK was still part of Europe, the pathway was to CE mark the device. So as an organisation, InnoScot Health took on the responsibility for legal manufacturer, and we implemented a 13485 quality management system to allow us to do that. Next slide, please. So the technology has been about for quite a long time. It was not the technology that was developed by the inventors, it was the implementation of that technology. So electroretinograms are used to measure electrical signals that are generated in the retina in response to visual stimulus. The ERG measures the response of a full field stimulus, and it generates a composite response that's made up from all of the different cells in the eyes, including the rods, the cones, and the ganglion cells. When you go to multifocal ERG, it uses distinct M sequences as a stimulus, which stimulates different regions of the retina independently. And that response allows you to gather local spatial information about what's happening within the retina. And it allows you to build up and map a 3D dimensional picture of retinal function. Next slide, please. So this diagram on the left shows the stimulus. This is a 61 hexagonal array, and each of these arrays will stimulate the retina independently in response to an M sequence. So the stimulus will either be on or off, and the retina will respond accordingly. The trace on the right-hand side just shows you an example of the stimulus when it's on or off and what the corresponding signal looks like. You can see in the images above that you can superimpose with SLO the stimulus onto the retina, and you can actually map out the regions so you can see exactly where you're looking at in the retina with this system. Next slide, please. So these are examples of the information that the system will provide you with. Clinically, there are changes in physiology due to disease much before you see structural changes. So the physiology will give you a very early indication as to what's happening to the eye health. In some cases, this can be used to monitor conditions. In other cases, it can be used to predict conditions and to actually identify at a very early stage whether someone is going to have this condition, but you will be able to see this before they even know this is happening. So these traces just give you an indication of some diseases that you could identify with this system. So at the top level, you have a normal image. You can see all of the waveforms are pretty uniform. Moving down from left to right, you see retinal detachment, where actually part of the response is non-responsive, so you're not seeing any amplitudes at all. With Stargardt's disease, you're seeing a very reduced amplitude in the central part of the retinal response. And with retinitis pigmentosa, you're not only seeing no response in the outer areas, but you're also seeing a slightly abnormal signal with respect to the amplitudes and the timing of the signals that come back. Next slide, please. So how was this implemented? There are 2 pieces of hardware and 1 piece of software in this system. And the 2 boxes have 2 distinct functions. So the head amplifier is really the data acquisition part of the system. It connects to the patient via an electrode that sits on the surface of the eye. These electrodes are commercially available, and the system was designed to work with most of these. In particular, DTL electrodes, which is just a fine wire that sits under the eyelid. So that connects to the patient and it recovers the electrical stimulus that is generated when the retina responds. The palette sequencer is the box which will actually generate the sequencing and which will retrieve the data and do the filtering required to allow the software to then take that information and with quite clever algorithms do the analysis necessary to cross-correlate the stimulus that actually caused the retina to respond in a particular way. And that way, what you have is one electrode taking many different responses and being able to actually identify exactly where they occurred. Next slide, please. So as part of the commercialization, we had to not only build the hardware, build the software, build the technical documentation for the notified body to show that the equipment was safe and effective, CE mark the device, but we also had to make sure that it was adequately packaged to make sure that wherever it went, it would be safe and would survive the journey, but also to put the branding in place, packaging that identifies what is in the box, and really just to make it a kind of attractive commercial package. So that whole process, from start to finish, I guess I have to say we had a few hiccups along the way, as we always do, with respect to markets changing and partners changing. But all in all, that probably took about 3 years from start to finish. And it was eventually placed on the market in 2008. And it was a successful product in that it was very niche in terms of the sales, but it was used quite prolifically in research institutes. So that's just an example of one of the ophthalmic innovations that we've taken from the health service. So with that, I'll pass back to Robert.
Great, thank you very much for that, Elaine. We've got time now for just a few questions. We've had a few questions coming in over the chat, and I'll actually start with one that I'm going to field back to Elaine, actually, given that you mentioned how long it took to bring multifocal imager to market. How long does it take to bring an idea to market, Elaine?
So I think the answer to that is, how long is a piece of string? It depends very much on the innovation and the complexity. That's very simple ideas can be brought to market very quickly. If you have a device that doesn't need a lot of engineering and is most of the way there, it can probably be done within 12 months. However, the complexity of devices will really take the time to get them to market, and it could be as much as 3 to 5 years.
Okay, thank you for that. We've had somebody ask, how much time will I have to spend on helping InnoScot Health develop my idea? How long, if I'm an inventor, how much time do I have to allocate, or do I have to allocate time? So I'll answer this one first. It really does vary. I would say the most successful projects that we do rely somewhat on the innovator giving us a bit of their time as things go forward. It doesn't have to be a lot of time, but if we're developing a prototype of a new device, we need them on board really to sort of review the prototype to see if it's what they had envisaged, see if it works properly, and then towards the latter stages of the project, I would say it's commercialization of a new medical device very much relies on having clinical champions, people who are using the device and working on the device, and actually happy to sort of champion it and persuade their colleagues, persuade others that it should be used and that it's worth using. That said, part of the reason InnoScot Health was set up was to take the burden away from the NHS, because we do realise, as I said earlier, that everybody has a full-time job and that you're busy people. So it's really as much or as little time as you're able to give and to devote to this. But I would say the most successful projects, do keep the innovator on board all the way through, and it works much better that way as a relationship. I don't know, Elaine or Graham, if you have any additions to that one that you want to add.
I think I would just like to say that we like people to be involved. I think it's very much a collaborative effort to take an innovation through the pipeline, and really we don't want to burden people with extra work to do, but if they want to be engaged, they can be engaged as much or or as little as they see fit.
Okay, thank you. So we've had somebody ask as well. Somebody's asked us, we mentioned that not all ideas that we work on are successful, and what are the reasons why they would commonly fail? I might start this one, and again, I'll hand back to Elaine and Graham as well. I think when we evaluate an idea, we look at a lot of different areas. We look at the market size, we look at what's current practice, and we look at whether the idea actually solves the problem. And we look at whether it will be a commercial success, will it save the NHS time and money? We look at whether somebody is already selling something that's substantially the same as that. And those are very often the areas where things fall down. Quite often we will have somebody come to us with a great idea, but there's already something out there that solves the problem. And we're not really in the business of reinventing the wheel if there's an easier way to help people, to help the NHS to get the tools that they need. So I wouldn't necessarily use the word fail. I don't think ideas fail in that sense. I just think that sometimes there are already things out there that do it, or sometimes the area is really too niche and the cost of developing it would be way too high. But again, Elaine or Graham, if you have any thoughts on why some of the ideas fail or why we reject ideas, that'd be good to hear.
I think one of the things just goes back to what we said in answer to the previous question, is if the innovator is unable to be passionately involved in his or her idea, then oftentimes that will just drag out the whole process and make it harder to deliver a successful outcome. Certainly when you're partnering up with a commercial partner, or we're thinking about spinning out a company. I mean, a lot of the time it's the innovator and their commitment and dedication and enthusiasm for their idea that will be a distinguishing feature. And obviously, the longer the process, the development process lasts, the greater the possibility often that something else will emerge that we hadn't foreseen at the start of the process that makes it harder. Finding the right partner again, once we actually have the idea at a state where it's ready to take to potential collaborators, bringing them to the table and generating the right degree of enthusiasm, that can sometimes be a hindrance to further progress. So there are a variety of reasons, but most of what we see is it will be down to just how much time and commitment the innovator has.
Okay, thank you for that. I think we've got time for just one last question. So one last question then: what would be your advice if I had an idea for modifying an existing idea or process that could have significant impact? Maybe Elaine, if you want to take that one.
So I guess it depends if you're an NHS employee or if you're an SME. If you're an NHS employee, really these small modifications are where we get our best innovation, because it's about how people change things to make things better for patients. Certainly if you're doing that, there are regulatory aspects associated with that, in that modifying something that's already available, you would have to make sure that your health board was on board, because that would be the equivalent of working off-label. If you were to then look to commercialise that would be really a new product. So I think the best advice, if you were going to do that, would be to come and speak to us here at InnoScot Health, and we can advise you of the best way to move forward with that, and to make sure that you're armed with all the information to make sure you navigate all the pitfalls of the regulatory parts of modifying a device.
Great, thank you very much, Elaine. So that's us on the hour now. So we'll wrap things up now. Thank you everybody for attending, and for people watching this in the future as well. I hope you found this useful. Thanks to my colleagues, to Graham and to Elaine for taking part, and thanks also to Dr. John Ellis. agreeing to be interviewed. And thanks also to the fantastic team at SHSC for hosting this event today. As Elaine said, contact us if you have any questions. Our details are there on the slide. And as I said, I hope you found today's event useful and interesting. And have a good morning to the rest of you.